All right, let's do this lab. Hopefully you guys can hear me back there because I'm not going to be shouting today. All right, and we really know most of this stuff, I think. This lab is dedicated to deep vein thrombosis, and we'll talk a little bit about arterial insufficiency. Deep vein, well, let me ask you right off the bat, deep vein thrombosis, does that cause arterial insufficiency or venous insufficiency? Venous, right? That's a problem with the deep veins. That's when a blood clot or thrombosis occurs. It causes a beaver dam in the deep veins. All right, let's look at our anatomy real quick. Here is the deep venous system. Let's check it out. This would be the abdominal aorta. Then we have common iliac, splits into an internal iliac, external iliac. Once the external iliac crosses the inguinal ligament, same vessel, but it changes names. It becomes the common femoral vein, not the femoral vein. There's a difference. Same with the artery. The artery becomes the common femoral artery. Why? I'll show you here in a second. So going down, we have a split. Whenever you hear common, there's going to be a split, and that's what happens. It splits the common femoral vein and artery, split into a deep femoral vein and artery. And then this remnant is just called the femoral vein. That's why you have to have common femoral vein here. It becomes the femoral vein. Back in the day, they used to call this the femoral vein and femoral artery, and this the superficial femoral vein and artery. But femoral vein is the main player in the deep system, the one that carries blood out of your lower extremities. 85 to 90% of your blood is carried out of your lower extremities through this deep system, including the femoral vein. So they used to call it the superficial femoral vein. Physicians would get confused when they got their ultrasound report back. Patient has a blood clot or thrombus, severe thrombus in the superficial femoral vein. And they would remember back to school and they thought, oh, superficial blood clots, that's not that big of a problem, which is true, but this is not a member of the superficial system. It's a major carrier for blood to get out of the lower extremity. So back in the 80s and 90s, they changed the name to femoral vein and got rid of superficial femoral vein and got rid of superficial femoral artery, because it's blood clots in the deep system that are incredibly dangerous. The ones in the superficial system are not nearly as dangerous. They can still cause a lot of swelling and trouble, but they're probably not gonna kill you. And that's because the superficial system, like the greater saphenous, their job is to dump blood into the deep system. Some blood can escape out through them, but maybe 10%, maybe 15%. All right, so femoral vein converts into the popliteal vein and popliteal artery. That splits into an anterior tibial vein, peroneal vein, posterior tibial vein. Anterior tibial vein, what does that one become? Let's see if your anatomy, if you remember anything. That's one of our palpable targets. Yeah, dorsalis pedis, right here at the crack of the ankle becomes dorsalis pedis. So anterior tibial vein is important, or the vein's not that important, but the artery would be important. Okay, let's look at quickly the superficial system, as I said. So from an A to P view, we remember this from anatomy, that big gigantic thing hanging off, very superficial. That's the greater saphenous vein, goes all the way down here and becomes part of the dorsal venous arch. Okay, it arises from a junction here of the common femoral vein, and we'll look at that junction here in a second, SFJ it's called. And now where's the lesser or short? The official name is short saphenous vein or small saphenous vein. That comes off the popliteal vein in the popliteal fossa. It sprouts a gigantic vessel, very superficial, posterior lateral part of your leg, and that is the small or short saphenous vein, which you can see goes down to here. Okay. Just to again review your physiology and anatomy, remember that most of the blood, 85%, maybe 90% of the blood leaves through the deep system. But most of the blood is generated in the superficial system and even the skin. So how does this work? How do you get blood into the deep system? Well, you have another system called the reticular system, that's in the dermis of your skin, in the subcutaneous tissue of your skin. There's a whole bunch of veins. They dump and drain the skin into your superficial system, which is made up of the saphenous, either greater or small saphenous vein, or branches, which we won't get into. I mean, the saphenous vein has branches like a tree. Then most of the blood is transmitted into the deep system via these things. Now, these are called perforator veins. And you guys didn't see those. Mama Z always cuts those things away so you can't see them. I just saw when they're dissecting the cadaver over there, and I wanted to look at it before she cut them away. These things are big. They're probably bigger than a pencil, like maybe like a marker size. They're big vessels. So the blood from the skin and the superficial system, that dumps into the deep system, like the femoral vein here or the posterior tibial or whatever. Some of the veins are inside of your soleus muscle in particular. We talked about in class how when you're standing and when you're swaying back and forth, blood is ratcheted out of your lower extremity. If I sway to the left here, my left soleus is contracting, blood is shot up a little bit. As I sway back, there's no pressure on there, the blood starts falling back down. That pops open the valves and catches the blood. When I move back to my left soleus contracts, the blood goes up further. When I move away from it, it starts falling again, and now it's caught here. So those valves are very important, so you can ratchet blood out of your lower extremity. Super important system. All right, that SFJ, anytime you have a whole bunch of blood vessels joining the area, that's called a confluence, or a junction. It's a saphenofemoral junction. And we can see there's the common femoral vein, and it splits into a whole bunch of pieces. The deep femoral is there. There's the femoral vein, and there's the greater saphenous vein. So those are all members of the SFJ. Why do I mention that? We said that these valves are really important for ratcheting and getting blood out of the lower extremity. If you damage the valves, it's very difficult to get blood out of your lower extremity. And over time, your veins start getting overpressurized. They start growing bigger and bigger and bigger, and you get varicose veins. There's one or two gigantic valves right in this SFJ. And if those get damaged, you get horrible varicose veins, because you can never get blood out of your lower extremity very well. It doesn't happen that often because they're so strong, but it can. And if you lose one of those two valves, you're going to have really bad varicose veins like this guy. All right, and this is mild. I should put a grosser picture in here. There's some horrible looking varicose veins, but and that's caused from valvular insufficiency, because his valves were damaged because he once had a blood clot. Question or stretching?
Why, for varicose veins, why do so many pregnant women get it? It's from valvular insufficiency.
What happens to pregnant women's blood pressure usually, and their blood volume goes up, right? Because now they have the blood of the baby and their own blood, so your pressure goes up, and the pressure goes up everywhere, including the veins. And so you just overpressurize. It's very common for them to get overpressurized veins. They stretch out, they don't come back usually. So it's just because of that extra body fluid that they have. Good question. All right, so with that said, let's talk about DVT, or deep vein thrombosis. We've talked about this in class, but deep vein means thrombus. It means there's thrombus, or we said that's kind of like a blood clot, a little bit different histologically speaking. But it's basically a blood clot of one of the deep veins. And here's a nice example. The blood clots usually occur right where these valves are. And here's a big piece of thrombus. And can you imagine the blood trying to get out of here? How is the blood going to get out? It's not going to get out. This is a beaver dam, and this is going to stretch and stretch. The pressure is going to back up. It can back up all the way through the microcirculation into the arterial side. It can get so bad. And as these veins stretch and stretch and stretch, they have pain receptors in them. And it can start to hurt, and you can start to get leg pain. So some people could walk into your office, they've been online, and they say, oh man, and back pain is so common. Maybe they have a little back pain as well. 80% of people deal with back pain once a month or more. They walk into your office saying, I got sciatica. I've been online and I have pain going right down my leg. And just don't take their word for it. Make sure we talked about this before in the lower extremity exam. Take off their pants, put them in a gown, and look at their lower extremities, because this can present exactly like sciatica. I'm an expert in sciatica because I have it. I've had it since 2002. And I've had one of these things as well. And I can tell you, even me, and I worked for a very smart neurosurgeon, spine surgeon, and we were both kind of fooled by this thing because I thought it was just a real bad flare-up. I didn't have a lot of these findings that I'm going to show you. I had subtle ones, especially toward the end. But it can really mimic sciatica. So if you have any of these findings I'm going to go over, make sure you send your patient to the ER so they can get an ultrasound and make sure they don't have one of these things. Because what happens if this breaks loose? Excuse me. Where does it go? Well, you follow the flow of blood. It goes into the heart, and if you're lucky, it makes it through the heart, but where's it going to get stuck? In the lungs. Because the vessels, and after the vessels, the pulmonary trunk, and then the pulmonary arteries, they get smaller and smaller and smaller, and this thing's going to jam in there somewhere, and you're going to kill off a decent piece of your lung tissue with this thing. And that's an infarct. And I've had that too, so I can tell you it's not fun. And if somebody would have caught this earlier in me, I wouldn't have had to go through all this stuff. So that's DVT. What causes DVT? Talked about in class. These people have a hypercoagulable state for some reason. And there was AKAs, thrombophilia, prothrombogenic state. We said coagulopathy is some authors loosely use that term for a hypercoagulable state, a blood clotting person. It's not a great term to use because coagulopathy means a pathology of coagulation. Maybe they clot too much, maybe they bleed, maybe they don't clot enough. So this is a horrible word. I won't use it, but just keep that in mind if you see that on a test, a board question. They probably mean hypercoagulable state with that. But hopefully the boards has that word removed from all their questions. What can cause hypercoagulable states? The blood clotting disorders. We talked about factor V Leiden mutation. Probably the most common genetic one. The most common acquired one is one called APAS, antiphospholipid antibody syndrome, which we'll get to in class. We said brand new cancer makes the blood get thick and clotty. That could do that. Prolonged activity. You just went on a 15-hour flight and we're sitting in the chair and your blood just kind of pooled. That encourages it to clot. We said SARS-CoV-2, the way it kills is by clotting, especially in your lungs. You get all these micro blood clots and it wrecks your alveoli so you can't breathe anymore. Surgery is another big risk for this. Hip surgery and knee surgery in particular. And the surgery damages a lot of the microcirculation, and they're not 100% sure about this, but they think von Willebrand factor is way over-secreted. And that's a powerful blood clotting agent, right, in these patients. So they're at great risk for clotting. Back before your time, there's a really famous talk show host, very right down the middle of the road, not too left, not too right. Everybody really, well, not everybody, but most people really liked him, named Pete Wilson. And he went in for a simple hip surgery, and he never came back. And what happened to him? He got a massive blood clot in his deep femoral artery. It broke loose, got stuck in his heart, and he died because his heart ran out of blood to pump. So it does happen. Serena Williams, the tennis player, also had one of these things. So it's out there. You don't hear a lot about it because people don't understand it. Why do we care about DVTs? Well, we said it can mimic sciatica, mimic radicular pain. And if you miss it, you're responsible. You're responsible to catch this. And sometimes the patients don't have the symptoms I'm going to talk about. And then it's not your fault. But if the symptoms are there, they go into the ER and their foot is swollen and red looking, and you miss that, you're responsible. The death rate from a pulmonary embolism, so if the thrombus breaks loose and a big chunk of blood flows downstream, we said, which happens, about if you make it to the hospital and get treated, there's still a 20% death rate from pulmonary embolism. So that's a very, very dangerous condition. The captain of, what was that show where they did the crabbing? It was on forever. The Deadliest Catch. That guy died from a blood clot as well. And he was far away from medical attention when it happened. For people who don't get in, it's probably over 50%. It's a very dangerous thing, so you got to try to catch this if the signs are there. Here's a perfect example of something you can't miss in your practice. So a patient comes in with sciatica. They have pain down their leg. They say, you don't need to take my jeans off. I have sciatica. I've had it before, maybe. I just want some flexion distraction treatment. It helped me before. So okay, let's get started. Don't have a patient tell you that stuff. You're the boss. You're the doctor. Say, no, Mr. Jones, we need to examine you, so go please change into a gown. And you get them on your exam table, and here's the sciatica leg. What do you think of that? That's no good, right? The blood is not getting out of the lower extremity because they have a gigantic blood clot, maybe in the popliteal or deep femoral vein, and the blood is backing up into their foot. And it's even starting to get erythemic. It's getting red looking. It's swollen. This guy, Mr. Jones, put your clothes back on. You need to go to the ER. This is a medical emergency. There's probably over 50% chance if you don't go to the ER, you're going to pass away from this thing if it breaks loose. So this is very serious. Oh yeah, I saw that swelling. I wondered what that was about. Yeah, they're not educated. They don't put two and two together. They just go on the internet and read some little 6-minute video, and it's not enough to understand this. But yeah, this is it. I mean, this is the end of the class really right here. If you see swelling and redness or pitting edema, which I'll show you here in a second, they're out of here. You write in your travel card, referred patient to the ER to rule out thrombosis. If they're having breathing difficulties and they come into your office and you see this, they had a PE. Part of that thrombus broke loose and it got stuck in their lung. So you need to refer them. I would have the patient sign your travel card that they understand. So if they don't go, well, it's on them. You did your job. You have to prove you did your job. You can also just give them a referral slip, make a copy of it, stick it in your file, and you'll be safe. I used to make them sign the travel card just to be safe. Okay, and we talked about how the backup overpressurizes the microcirculation, and the distal capillary can't withdraw the extrainterstitial fluid if its hydrostatic pressure is way off the chart. Just the opposite, you leak blood fluid through the distal capillary and through the proximal capillary. And you have way too much blood around. It's stretching all the capillaries and starting to hurt. Okay, so this would be an acute situation. And maybe our patient has never had anything like this before. So you're not going to see skin changes. They're not going to have those brawny indurations, those stains around the gaiter area. They're probably not going to have the varicose veins. And that's normal. Kind of remember that because we're going to talk about that in a minute. But that's normal. Everybody's, like if you looked at your feet right now from sitting there, your feet would have veins kind of popping out a little bit. But in patients where this has been going on a long time, maybe they had a blood clot 10 years ago, and if you damage your valves, you're always going to have too much pressure around your ankles, and your skin is going to start being affected by it, no matter how careful. Mine has been affected by it, and I'm super careful with it. So people who've had this going on a long time, they're going to have those skin changes. Where are they? They're going to have this brawny induration, that's called, where red blood cells have been forced into the interstitium. There's no way for them to get back into the bloodstream. They explode and release hemosiderin, which stains the skin brown. From chronic pressure, you start to get little varicose veins in all those in the reticular system. This is what my leg looks like. It's not this bad, but I'm super careful with mine, and it's been almost 10 years, I think, since mine. But yeah, so if someone came in with this and they had sciatica going down this leg, your antenna should go boom. You should be really, really careful with this, because the chances are much higher that the sciatica is really from a blood clot. All right, key findings we said already: swelling, erythema, red skin. It'll be warm to the touch. If it's been a long problem, telangiectasia, brawny indurations. We already talked about last week, I think, how to palpate. Use the back of your fingers to check for warmth. Maybe they're a person of color and you can't see their skin color. You won't see the red color on them. But you can see the swelling and you can feel the hotness. I mean, if this is their sciatic leg right here and it feels hot to the touch, they got to go. You got to send them to the ER. All right, we talked about last week how to check for edema, especially in a person of color where you can't see their skin color. You can push right there on the medial border, kind of the medial part of that tibia bone, which is flat, and you can check by pushing in there. If it leaves big pits right there, and the non-sciatica leg has no pits on it, they go right to the ER. They got a backup of fluid there, right? Like this person. That's called pitting edema. And there's a difference, pitting and non-pitting edema. I won't get into that, but probably going too far into the weeds. Can an arterial pulse predict a DVT? This is an interesting question. Mine was still present, and I had really bad thrombosis, and mine was still working. I didn't have that much swelling. But if they have a lot of swelling in their foot, you're not going to feel a dorsalis pedis or posterior tibial, because the backup of fluid has went into the arterial side, and it's kind of slowing the flow of arterial blood down. I looked at some papers last night actually on this just to confirm that. So it's not a great test. I wouldn't put too much stock in the pulses down there, because they could be decreased, they may not be decreased. All right, the tests for this, really the lecture is over. These tests are really for board purposes. I wouldn't do either of these tests. You can maybe do the Homan's test just to kind of cover your butt, but it's really a worthless test. Modified Perthes test, probably that's not going to be on boards. It's a better test, but I worry that by pressurizing the deep system, you might cause a thrombus to break loose and cause a DVT. So I took that out. That's just getting too risky. Homan's test, and who are these tests for? These are for your sciatica patients. If you have a sciatic patient come in, you can do this test on them, especially if they have pitting edema or swelling or erythema or increased temperature. You should do this test. Personally, I wouldn't do it. I'd just send them to the ER. If you want to do it, it's fine. The sensitivity and specificity for Homan's is about 30%, which is really a waste of your time to do. It is on boards, though, so you should probably do it. Okay, everything I said. All right, let's look at Homan's test or Homan's sign. It's a test for detecting deep vein thrombosis, not superficial venous thrombosis. And really, it'll only detect thrombus that is in the calf or in the lower extremity. It's not going to catch the more dangerous ones in your thigh or even in the popliteal system, the popliteal vein. It's not going to catch it there either. If you do have thrombus forming in the posterior tibial, all those vessels, peroneal vein, if you have thrombus forming there, it might actually catch it there. But a terrible, terrible sensitivity is 30%. Okay, but here's how you do it. And I mean, here's the problem in someone with sciatica. It's a Braggart's test. You guys know Braggart's test already, right? What is Braggart's test designed to do? To provoke sciatica. You're stretching the sciatic nerve, and if the sciatic nerve is inflamed, the patient's going to recreate that tingling, that burning sensation that they have in their leg and maybe even in their thigh. So it's a terrible test. It might be positive because their sciatic nerve is inflamed. So that's why it's got terrible sensitivity and specificity. But nevertheless, if you're asked to do it, you just do a Braggart's test. Dorsiflex their foot or when their leg is straight, and that's it. If they have pain in their calf, the test is said to be positive for, now McGee still uses that old dinosaur terminology, deep vein thrombophlebitis, which we tried to get rid of in the 80s and 90s, but he's still, this book just drives me crazy, but it is a board book. So it's positive for deep vein thrombophlebitis. The newer terminology is deep vein thrombosis, or DVT. If you see that, just think DVT. And we'll get into the difference on those in class. All right, the vascular surgeons and who have put out books, they recommend doing the test like this, bending the knee, and that will kind of let the sciatic nerve relax and not be stretched as much. So if you bend the knee, it takes the sciatic nerve supposedly a little bit out of the play. And you still dorsiflex, and if they have pain in the calf here, it's positive for deep vein thrombosis. On boards though, because those are not board books, on boards you should probably do it just like a Braggart's test. Okay. Watch out for a Baker's cyst. Some people will get pain in the back of their knee when you do this. It's a common cyst. I don't know, you'll get to, I don't think you've had that yet, but it's a really common cyst that lives in the popliteal fossa. It can cause knee pain. People think they hurt their meniscus, and really they have a Baker's cyst back there. So that's one of the differentials. Okay, so that's the end of the presentation really for the venous side. What about arterial insufficiency? So we said arterial insufficiency means the artery is pinched off or clogged, or something is causing decreased blood flow through the artery, and downstream is not getting enough blood. So we're talking about the lower extremities, so your feet are not going to get a lot of blood. So what's that all about? So they developed this Berger's test to kind of test for arterial insufficiency. Remember, key point, Homan's test is for venous insufficiency. That's looking for DVT. Berger's test is looking for arterial insufficiency. I always ask that on the midterm, and I always tell you about half of you are going to get that wrong, and you still get half of you get it wrong. But make sure you know the difference. Berger's test is testing the arterial pipes to make sure the blood's flowing. Okay? Homan's test is testing the vein pipes to make sure the blood is flowing through those. So Berger's test, well, we'll go with these causes here in a second. Let's show you what it is. So Berger's test is another kind of straight-legging raised test. So the patient is supine, and they're on the table, and you lift both of the legs up to 45 degrees. You take the shoes and socks off, lift them up, and watch what happens. Normally what happens is the feet might get a little bit white, not like crazy white though. Maybe those veins that we saw in that other picture, they collapse because now you have gravity pushing against the arterial blood flow. So you hold it there, and if nothing really happens, the test is over. It's negative. They don't have arterial insufficiency. But if one or both of their feet get really white, like this patient here. So here's a patient with, I think she had atrial fibrillation. She had a lot of pain behind her knee, and it turned out to be a blood clot, an arterial blood clot. An embolism had released and blocked the popliteal artery. And when they lifted her feet up, within about 40 seconds, her foot was ghostly white. So that tells you, well, there's not a lot of blood getting up to the foot. This one looks fine. But that's a positive finding. That's a positive Berger's test. It indicates arterial insufficiency. AKA for pallor is blanching. McGee sometimes calls that blanching. So blanching and pallor are AKAs. Okay, I think we got that covered. Now, what does it indicate? What does this patient have? Well, really all you can tell at this point is their arteries aren't working. They're clogged by something. So that's called arterial insufficiency. It typically occurs from peripheral arterial disease. It would probably be bilateral if that was the case. But anything that clogs the arterial pipe upstream can cause it. Tumor, lymph node, arterial thrombus, embolism, that can all do the trick. So you have to put on your detective hat and maybe try to figure out what it is. But it indicates arterial insufficiency. Part 2, if the test was positive, so if that was your patient, just to confirm, you can go to part 2. And what's part 2? You just have the patient sit up with their feet dangling on the table. And now you watch the blood return to their feet. If the pipe is clogged, if the artery is clogged, it's not going to come back to color. It's going to have a delay in turning back to its normal, like rosy red color. Normally, if we did this to you guys, within 15 seconds, your feet will return to the little rosy red color. That vein, those veins would maybe kind of rise up again like they were, and everything is good. So 15 seconds, you need to remember that. What's a positive finding? Well, if it doesn't come back within 15 or 20 seconds at the most. And I'm not going to test you on 15 to 20 seconds means moderate arterial insufficiency. 20 to 40 seconds is moderate to severe. But I do want you to know this one. So if you're waiting and waiting, it's your 40 seconds and their foot is still white looking. That's severe beaver dam somewhere. They have severe arterial insufficiency and they're suffering from severe ischemia. I mean, they're on their way to getting ulcers and other skin changes because of this. And then you might even, if you're lucky, sometimes what happens is their foot all of a sudden turns rock lobster red, just red as can be. And that would happen after 40, 60 seconds or so. And then what's the story behind that? How does that work? Well, we have to go back to this to understand this phenomenon. So if your foot is up for 3 minutes like this, the tissue is, it's dying. It's freaking out. The blood vessels are trying to, the only thing they can do is maybe increase their diameter to get more blood. So nitric oxide is released by the epithelial cells like crazy, but it can't do anything. It can't even get into the cells because the river's not flowing, so it just sits there. Maybe even backs up a little bit. So you have a ton of nitric oxide just sitting outside the epithelial cells. Over here you don't have any. When you put your feet down like this, finally you got gravity and you got blood flow again. That nitric oxide gets pushed into the to all the tunica intima cells, gets into the tunica media, and the blood vessels just pop wide open, and blood comes flying in too much. And that's the key buzzword is called dusky red. Now, if you see this dusky red in part 2 of Berger's test, that strongly indicates a severe beaver dam, and their tissue is not going good. They'll probably start to have skin lesions, like this guy's got some ulcers here and there. Looks like maybe he's had a surgery up here. But make sure you know what dusky red is. All right, that is it. If you want me to demonstrate anything, I'd be happy to do that. If you want to go study, you can go study. I have demonstrations on my Professor Doug's lecture page that you can watch. It's pretty straightforward.